All right, we're in. Off to you, André.
Thank you, Véronique. So welcome, everyone. As you know, we've been having several of these seminars over the... Hello? Yeah, it's good. Over the past few months. I think this is in part how we're ending phase one, which officially ended like a couple of weeks ago. So we're looking back at how we did things during phase one, but also getting ready for the phase two. Now in phase two, as you probably heard, there will be greater emphasis on deliverables and impact. So not only cases will have to be prospective, but also there will have to be significant efforts to reach underserved populations, to show impact on cancer diagnosis and treatment by using appropriate cohorts, and ultimately implementation in one form or another, facilitation of implementation of precision oncology in oncology practice across Canada. So you will be hearing more and more of these seminars as we go, because there will be more and more deliverables. Obviously, at the beginning, it won't be right away, but I think this is going to be an example of the type of seminars that we're going to have more and more often. So today we're talking about the biospecimens, and I'm not going to say much more because we have Jenny and Véronique who are then taking over from me.
Merci, André. Thank you and welcome, everyone. We do indeed have some fantastic talks coming your way, so I won't take long, but I just wanted to get started with a little bit of housekeeping. We will be keeping questions until the end of the seminar, so please either type your questions in the Q&A, which you can find at the top left of your screen. It's the two little speech bubbles with the question mark. Or at the end, during the Q&A session, you can raise your hand and we'll allow you to unmute and ask your question live. I also want to take a moment to acknowledge that I personally am calling in today from Mi'kmaq, the traditional and unceded territory of the Mi'kmaq people. Our network members and our speakers and our attendees here today are located all over the country on lands that are home to diverse First Nations, Métis, and Inuit peoples. And I invite everyone here to honor and pay respects to those peoples and reflect on the importance of the land and waters that we all currently call home. I also have the great pleasure of introducing my co-chair, Jenny. Jenny is one of the inaugural members of the network's patient working group, and she's been involved in so many different aspects of the network over the past 3 years. So thank you so much, Jenny, for everything that you do, and also for generously volunteering to co-chair this seminar. So I'll pass it to you if you'd like to tell us a little bit about yourself and then get the seminar started.
Sure. Thank you, Véronique. Good morning, everyone. I guess it's afternoon now. From Winnipeg, Manitoba, that's my home. My name is Jenny Graham, and I just want to say that Winnipeg is located in Treaty 1 territory, the home and traditional lands of the Anishinaabe, Ojibwe, Innu Cree, and Dakota peoples. And we are in the national homeland of the Red River Métis. And our drinking water here in Winnipeg comes from Shoal Lake 40 First Nation in Treaty 3 territory. So I'm grateful for being able to be here with you today. And I'm pleased to open today's seminar with a few words about my cancer experience. This is a very important time for cancer research in Canada. Precision oncology is already making a difference in the lives of many Canadians living the cancer experience. I'm one of them. I was diagnosed with and received chemo for an early stage invasive ductal breast cancer in 2012. Last year at this time, I was investigating perimenopausal symptoms, and by the end of May, I received an endometrial cancer diagnosis. So, pathology is done after the surgery. That revealed bilateral ovarian cancer as well. Surprise. Both were low-grade endometrioid carcinomas, and I just finished 2 months ago now my last cycle of paclitaxel carboplatin chemotherapy for the ovarian cancer. So I'm pretty excited about that. But, my curiosity is gearing up to learn more about all of this, because I've now had 3 primary cancers, 3 hormone-related cancers. Why is that? So my path to diagnosis and treatment began because I asked why, and persistence pushed me forward to inquire, and my curiosity and storytelling led me here today to be with all of you, a passion-filled group of patients, researchers, practitioners, and you're all now a part of my story. So thank you again. So I've learned that endometrial cancers are a little bit tricky. Learning about them as a patient requires care and caution. And so I work in adult education. I'm a lifelong learner, and that's really helped me cope with cancer. But there's a striking difference through the knowledge base and patient education and social supports available for endometrial cancer compared to breast cancer, ovarian cancer, all the gynae cancers. So I'm still learning, and I have a lot of questions, probably more now than answers. And I know we can do better as a group to inform and to help everyone get through their diagnosis and treatment. So team is a huge word in my life. I'm very happy to be a part of the Marathon of Hope Cancer Center Network Patient Working Group. We are all here today because we are meant to be here. We are here to learn from each other and to be inspired by what the network is bringing to Canadians. So with that, I'm going to get to introducing our amazing speakers for today. I thoroughly enjoyed our pre-seminar chat, so thank you, everybody. And I would like to first introduce Dr. Anne-Marie Mes-Masson, and she is a professor in the Department of Medicine at the Université de Montréal and the Associate Scientific Director of Basic and Translational Research at the CR-CHUM. She is also co-lead of the Marathon of Hope Quebec Consortium. Dr. Peter Watson is a professor of pathology at UBC, a staff pathologist with BC Cancer, and a senior scientist with the BC Cancer Research Centre. Today, Drs. Mes-Masson and Watson will be telling us about the Canadian Tissue Repository Network, which they co-lead. Take it away.
Great. Well, thank you very much, Jenny, for that introduction. Thank you also for grounding us, and thank you to the network for the invitation to speak. I'm just going to share my screen and get the slides up, and you should see presentation mode in a minute. Here we go. Okay, well, thank you for this opportunity. I'm going to talk with Anne-Marie about the work of the Canadian Tissue Repository Network, or CTRNet, and its aims to ensure biospecimen and data quality across the realm of cancer research. So CTRNet was launched more than 20 years ago because of a recognition across the Canadian Cancer Research Alliance that there were significant weaknesses in our tumor biobanking landscape. So since then, CTRNet has been consistently identified as a key ongoing component of the Pan-Canadian research strategy, and its work remains highly relevant to the ongoing vision. So over these years, CTRNet has had key core support from many funders, but in particular from the Marathon of Hope Network, from TFRI and CIHR, and many other CCRA funders, and very important support locally from BC Cancer, from RR Cancer in Quebec. And since the beginning, as sort of shown in the graphic, CTRNet's strategy to improve the biobanking landscape is relatively straightforward. It's centered on three components. Firstly, developing and maintaining national standards for biospecimens and data. Secondly, establishing QA programs and offering data software to encourage dissemination of these standards. And obviously trying to improve access to quality biospecimens and data. So of course, good governance is a key component of any strategy. And CTRNet's governance looks like this. It's developed over time, but this is where we are now. The operations of CTRNet are mostly consolidated in BC and Quebec under oversight from myself and Anne-Marie, but the leadership comes from a much broader executive, and the overall direction and strategy is guided by an even broader college of advisors. The membership of both of these is shown in the table below. So the structure fosters input from both national research stakeholders and provincial biobank networks in order to remain responsive to research needs. The key product and output from CTRNet is a comprehensive set of national standards for biobanking. This CTRNet standard has over 360 discrete elements. It covers all 13 aspects of biobanking, from enrollment through to research access, as depicted in that very small graphic. And it's also closely aligned with the more recently published international ISO standard for biobanking. But the CTRNet standard is more accessible and it's much broader in its focus. And I think this has contributed to a higher uptake of the CTRNet standard, not just nationally, but also internationally. In addition, CTRNet has developed a range of other supporting products and assets. These include, as I mentioned before, these mechanisms for dissemination of the standards through QA programs and a data management system that Anne-Marie will talk about in a moment, but also many other products, education and training, SOPs and tools, locators and finders to assist researchers to find and access biospecimens, and support in general for biobanks. We've also published over 30 papers in the last 10 years on a range of biobanking topics that span from novel approaches to participant enrollment through to trends in biospecimen utilization. Our biospecimen quality strategy is based on 3 quality assurance programs. These target the key nodes in the main pathways whereby biospecimens are obtained from participants and utilized in research, as depicted above. These programs specifically target pathology departments, biobanks, and research labs, with the relevant information for each and accompanied by the standards, the education, and support. Although customized for each program, the programs all depend on the same core components. Those are shown in the table below. These include those standards, but also over 100 SOPs and policies and operational documents, and 2 comprehensive online education courses that are designed respectively for biobank staff and for research staff and trainees. Now, these components were all created with reference to international best practices that are set by the International Society for Biological and Environmental Biorepositories, or ISBA for short. And importantly, these CTRNet components not just are created, but undergo continuous review and updating to ensure that they align with these external references as biobanking practices evolve. And this slide is just a snapshot of the current status and uptake of these programs and products. There are now more than 900 individual biobanks, networks, and clinical trial sites that are enrolled in our various QA programs. Approximately 75% of these are Canadian, and as shown on the figure on the right, the national uptake is distributed nicely and evenly across the country. There are more than 8,000 learners enrolled in our biobank education courses. Over 4,000 of these are Canadians, but as again indicated on the right, there's also significant international uptake through our partnership with ISBA. In addition, there's been 20,000 plus downloads of our policies and SOPs, and biobanks in other countries, Australia and Germany of note, have adopted our programs and products. And several national research funders here in Canada and institutions have made enrollment into our programs a requirement for receipt of research funding. So I'll now just hand over to Anne-Marie to describe the CTRNet data quality strategy. Over to you, Anne-Marie.
So of course, the quality of the data has to be as good as the quality of the biospecimen. So initially when we designed and we were thinking of this, we had some key features, excuse me, that we wanted to incorporate into our software. So one is we wanted to be open source so that we could have web applications and it would be easy to install. We wanted to make sure that it supported all aspects of data that we generate during biobank activities. So not just those around the consent and the samples, but also those related to the participant. We wanted it to be highly customizable so that people could use their own logic when introducing data. But we did want to promote data standards, and we've continued to do that over time by including international standards as they get described. So standards like ICD-10 for disease codes or RX norm when we're looking at drugs. We have custom library forms that can be made for specific disease sites, and we help different biobanks that collect the same types of tumors to share these. We have a full audit trail. We needed to have reporting and query tools, the ability to share data between different software systems through API. And of course, the software has undergone constant improvement, not just by the developers here in Montreal, but also through a network of developers across the country that contribute. In terms of the ADAM solution for at the biobank level, so if we could have the next slide. What we were looking at, we recognize that biobanking is an activity that is poorly funded, and that if we wanted to have uptake of our solution, we had to minimize the costs. And so the ADAM solution, the name of our software, is either free in some instances for new biobanks that don't have to import data, or if there are more complex installations and you have to migrate a lot of historic data, it can be more expensive. There are no real constraints since it's open source. I mean, it's freely available to anyone, and there's no long-term contracts and no recurring costs, so there's no annual fees, for example. We've been around for a long time. We have survived on largely initially grants. We have now a billing strategy that just to cover costs, and we have the developer community, which helps us evolve. We are partners, of course, with, we want to promote good biobanking practices. So when we install the software, we also redirect biobanks to CTRNet and the Biobank Resource Center to promote registration and certification of banks. We support the biobanking community also by promoting good practices for data collection. We have our own training that's associated with ADAM, and we have now we have customer support since 2023 of a ADAM platform at my center where people can come and get support for ADAM. So the ADAM data model is really two large modules. So one is the participant, that's clinical annotation. So not only does it follow the consents, but it follows all the important parameters that we would want to know about participants, whether it's reproductive history, family history, their clinical events and labs, their diagnosis and their treatments, and it can be continuously updated. And then we have the other module, which is in oncology quite complex. It's an inventory management, because unlike population-based biobanks, we actually have a lot of different tissues that we can collect, and they each bring their own complexity. So in addition to the tumor tissue, which is either fresh or FFPE, paraffin embedded, we can also have live derivatives, we can have bloods, we can have the microbiome, we can have ascites. So we have to be able to track all these different types of specimens. We want to make sure that they meet quality standards, so we include information of all quality controls we do. We have ability to follow their storage, their path, for tissue microarrays. For those people who know what they are, we can bring together collections of different blocks. And so when a study comes to us and gets approved, ADAM can quickly provide the data either of the participant or the specimen that's being provided for any particular study. Next slide shows you a little bit of how ADAM has evolved over the years. So this was CTRNet started back in 2004. We did an analysis of what was available then and realized there was really nothing that met all of our needs, and that's why we started actually creating this solution for ADAM. The first version was basically beta tested in Peter's lab and in my lab. It evolved to ADAM 2.0 with a major reboot of the project. And then we have continued to disseminate it throughout the years, all the while improving it, including new features. In 2003, we have now created a support platform where people can come and get support directly. And I want to talk to you at the end about a project that we've started that's called My BioKey. But just on the other side, you see that we have a lot of partners in this. And if you look at where our clients are, they're almost completely across Canada. There's 8 out of 10 provinces. Prince Edward Island doesn't have a biobank, so they don't have. and we still do not have any installs in Alberta. But otherwise, there's been wide uptake across the country of this tool. If I can have the next slide. So, of course, we're talking today about the Marathon of Hope, and so as our partner, we have created a specific atom which is compliant for the Marathon of Hope, and the one that we use in Quebec has specific features that allow us to be very efficient in our data capture for this project. So the atom Marathon of Hope Quebec install has all the clinical annotation in the dictionaries as they're defined by the clinical working group of the Marathon of Hope. So when a sample gets included into it, that sample data is transferred to the atom MOH-Q, and it receives its specific identifiers for this project. Then that information is shared with the institutional data lake. The institutional data lake will extract the data as it needs to be extracted in a form that's appropriate for the data dictionary of MOH. That clinical data that gets returned to ATOM, it is curated and verified by an ATOM user, and if need be, then additional clinical data can be input by manually. That data is then exported to a C3G in Quebec, which is also associated with the sequencing data. So now it's possible to associate the specimen, the clinical data, and the sequencing data, which is then shared with CanDig, and CanDig then is responsible for distributing through the network. At the same time, when the sequencing is done, then sequencing reports are returned to the ATOM MOH-Q so that we know all the quality metrics of the sequencing, and we know all the identifiers of the sequencing so that we can track all activities. So this work is done in the sites in Quebec, done automatically, and we have also shared this version of the MOH ATOM with New Brunswick, which also uses it as its tool. So I just want to finish up by talking about our next project, which is the MyBioKey. It's our next. It is our next software solution for biobanking. So why are we looking at going to a next solution? Well, we have certain features that would be very difficult to incorporate into ATOM. One of them is really having a central software where you could partition out the data. So different biobanks would only see their own data, but they're all sitting on the same MyBioKey technology. The technology we use to make ATOM is now almost 20 years old. We have continued to update the backend, but there are new technologies out there that are much more efficient. So we are working on changing into a fully new platform. We want to promote data interoperability within institutions and between institutions. Of course, we're going to continue to encourage data standards and how we share data. We are documenting the entire process so that we are going to be ISO certified. We're trying to make it more visually pleasing and intuitive. It's a scalable concept, so we can start with a smaller version and add features over time. And really, this is going to be a key solution for precision medicine, especially in centers that want to practice this across multiple disease sites, not just oncology, but different cancer sites. So basically, we have two client models. There's a model where you have an install at an institution, and every biobank within that institution then would use that single install to create their biobank project within MyBioKey that they could either share with others or keep it cloistered. The other way to see it is a cloud installation, and who would be interested in this? We think that biobanks and centers that don't have an institutional MyBioKey would be interested in accessing this software, which would be very powerful for their needs. But this would be a low-cost solution for a Canadian biobank to be able to store their data. Or it could be consortiums across the country if they wanted to be able to share their specimens and data. and work on the project together, they would favor a cloud solution. Back to you, Peter.
Thanks. So very briefly to summarize, what CTRNet has accomplished to date is it's created a cost-effective and internationally recognized biobanking quality programs, it's provided open source data management solutions that are tailored to Canadian research, and it's effectively disseminated national biobanking standards across Canada. And so going forwards, we think CTRNet's programs and products still play a critical role in supporting research and discovery because it prevents funders investing in duplicate and poor quality collections, ensures reproducibility of the data generated from biospecimens. It's important to disseminate further fair data principles for all biospecimens, and of course to maintain public trust in our biobanking. So very finally, thank you to all our funders and partners who have supported CTRNet over the years. Thank you to the people and biobankers and collaborators who've been involved in CTRNet over the years. And of course, most of all, thanks to the patient participants who so generously donate their biospecimens and data to provide what is a critical fuel for cancer research. So thanks all, and back to you, Veronique.
Thank you so much, Peter and Anne-Marie. That was fantastic. Jenny, do you want to keep us going?
Yes. Wow. I mean, wow. I like learning. I love a good SOP, and it is clear to me that so much work has been done in the background. It kind of brings me to tears, appreciating what goes into coordinating and coming up with the ideas and all that goes into, you know, simply take my tissue. So I'm amazed by that. Thank you so much for your presentation. So like I said, it's clear to me that much work is being done in the background. And, you know, considering everything that's happening in the background, I am just wondering, and this is a question just for pondering right now, but, you know, how can patients and people living with cancer sort of respect that what's happening in the background? How can we bring it into the foreground? So, you know, I, as a patient, I want to know, how can I access, like, how can I submit all my tissue, whatever you need, into the biobank? We can answer that question later. But before we get to the Q&A, I think our next speaker is going to provide us with some information that will help us all gain more awareness about the importance of biobanking and all the work that goes into it, and making that available for all Canadians. If you have yet to hear Dr. Nadine Caron speak, you are in for a treat. Dr. Nadine Caron is a surgeon at University Hospital of Northern BC, the First Nations Health Authority Chair in Cancer and Wellness at UBC, and a founding co-director of the UBC Centre for Excellence in Indigenous Health. Dr. Caron also leads the Northern Biobank Initiative and the Northern BC First Nations Biobank. And we're excited to hear what you have to say, Dr. Caron.
Thank you so much, Jenny, and a great presentation to start us off. Wow, a lot of information in there, and just tremendous work. Chimigwech, merci, thank you for just the honor of presenting. I know some of you have heard over the years the progress of the Northern Biobank Initiative, and I'm looking forward to sort of summarizing the last 15 years, really. While I'm putting the presentation up, I'm going to introduce Gwen Point, who's going to open us up in a good way with respect to this topic and the work that we have been doing. So Gwen Point is a knowledge keeper from the Stolo First Nation. She is a key part of the work that I do with respect to the First Nations Health Authority Chair in Cancer and Wellness, and in projects that span everything from advocacy for patients trying to get cancer care to the research and developing the research platforms like biobanks and databases in the field of genomics. So Gwen, I'm going to pass it off to you, and while you are sharing an opening for us, I will put on the slides.
Well, Nadine, to everyone online, Tetel 8 is Shashko with the Hummel to Squeen, Halchamel the Hummel to Stalo. I'm saying thank you to it, and to Iatalatal is I thank you. for today, and I appreciated the presentation, the earlier presentation. Great, it is great work. Yayas in our languages work. My traditional name is Shashkowit, and I'm here in Stolo territory, what they call Stolo. If you translate that, means river people. And I'm just so grateful to each and every one of you. The elders tell us to eat the people, thank the people. And the Yayas, the work that you're doing, it's so important, and it's one of the reasons why I agreed to work with Nadine as well. But I'll tell you this one statement she made. If you can imagine, we're not represented in all the areas where we should be represented. We're just not. And we're the ones that have academic or professional backgrounds like Nadine, or if you're a lawyer, if you're a doctor, we're just not represented. But the one statement Nadine made that drew me to her was this. And she said, I'm tired of giving medicine to my people that was made for someone else. And you know, that's true. My background is education. And I can say it's the same, whether it's education or the legal system. We're overrepresented in the healthcare. We just are in all the areas. Diabetes, high blood pressure, cancer. A lot of our people die with no treatment. You need to know that. A lot of our people won't go to a hospital, won't go to a doctor. I had a younger cousin, younger than me, early 50s, and she died of something that could have been repaired with minor surgery. I really need you to hear me when I'm saying this. And so when Nadine said that, I thought, you know, I'm going to walk with her. I'm going to walk with her, support her in whatever way I can. I'm the knowledge keeper for our BC Assembly of First Nation Chiefs, majority of First Nations. I'm also sent to Ottawa to work with the knowledge keepers across Canada. So I brought Nadine's work to the knowledge keepers across Canada, you know, and I share wherever I can. And if I learned anything, it's this, is partnerships work. Partnerships work. And I heard you when you said you don't have to recreate the wheel. But partnerships with First Nations just doesn't happen, right? They don't trust because we've been researched and, you know, we're used like guinea pigs in the early days. Let's see if we starve them, you know, how long do they last? You got to look into that history of what they did medically to our people. So there's not a lot of trust, that's what I'm saying. But if Nadine walks in a room, you know, people know who she is and they know her work. And so this is such an important, so important. It's so important. I tell whoever will listen to me about this work. And of course, Terry Fox, you know, just recently claimed Métis. Their family did, right? And I ran for Terry Fox for 15, 20 years, right? And that money didn't necessarily benefit my people. But I do it all over again because the work you're doing is so important. I'm going to stop there, but I'm sending special blessings to each and every one of you, and especially Nadine, And our people say, Lutzamad, Lutzathala. Have a one mind and one heart. And that's what I witnessed with your work at the beginning there, all those names you put on there for people that are doing this, so others can live a better life, right? And even be cancer-free. So I'll stop there. Thank you.
Thank you, Miigwech, Gwen. I hope that everyone can see the benefit that I have every week working with Gwen. I want to acknowledge also there's many of the team from the Biobank that are also joining us today, and they've done everything to be in the trenches with me, to helping me prepare the slides for today and everything in between. So how can we keep really the north part of Canada's DNA, Indigenous people, rural communities, and how smaller projects can be part of big aims with perhaps, and obviously, I think the biggest aim in cancer research to date being exactly this, the Marathon of Hope. So this is relatively recent data looking at projected age standardized cancer incidence rates, and you can see that there's a difference across the country. I think we're all, when it comes to one heart, one mind, we're all aiming to shift this all the way over to this area in terms of incidence and ultimately win this battle against cancer. There are disparities across the country, and you can see here these are age standardized and include both sexes. And a lot of times the research, when we look at just simply demographics of data, they don't go into things like Indigenous or First Nations, Métis and Inuit. They don't go into rural or remote or urban or metropolitan. They don't go into some of these things that can affect everything with respect to health services, nor environment or risk factors or potentially genomics. Similarly, same publication that came out from CCS, this is looking at the mortality rates. I want to just highlight that there are disparities again, but interestingly enough, where there's the least incidence, if you do get cancer, there's the highest mortality rate. And when you look at the territory of Nunavut, it does have the highest percentage of Indigenous peoples of any jurisdiction in Canada. And you can see that there is disparities across the country. The Marathon of Hope Canadian Spectrum Working Group, I hope that we all know these mandates, but it's really to break it down, the inclusion strategies for underserved and underrepresented populations. And I know Amber's joined us today, Amber Teed, who has been just an absolute joy to work with in this space, along with the entire Canadian Spectrum Working Group, which I'm just so lucky to have even met in this journey. We're looking at socio-demographic data fields so that we can start to understand cancer that's at a level that's even more important. And Peter, and we showed sort of how you can collect that data. And then also supporting working groups, other working groups for recommendations to include diversity and inclusion, but also I think the other nodes. And as we go into this phase 2, how can the Canadian Spectrum Working Group work with each of the nodes across the country so that we can aim for that equity in terms of representation in this undertaking that we are all joined together and partnering on. The goal of the Marathon of Hope was exactly this. We should have it memorized by now, but I think the thing that really hits home is delivery of the best outcomes for every cancer patient in Canada, no matter where they live. And I think we could even extend it to no matter where you are, no matter who you are, no matter the color of your skin, no matter who you love, no matter what your age is, no matter what your background is, no matter who your parents are. And I think that is the foundation of what Terry was hoping for. We want to keep the north part of Canada's DNA. This is a slide. Peter, thank you. Isabel, thank you for helping to create this, or for creating this slide. And what we wanted to just sort of show that when the Northern Biobank Initiative was taken under the wings of the Marathon of Hope, I think we were able to sort of become an example, not the only, but an example of it. You can have a community hospital that serves rural, remote, northern, and Indigenous populations and be part of this fabric of biobanking and the subsequent research that is going to find answers, create new treatments, new diagnostics, new screening, new prognosis. I think it's really, really exciting. So why a Northern Biobank? I picked this picture because if you can look at the back, the Terry Fox Research Institute, This was Mara's initiative with respect to the research advisory committee that he started with the BC node with the TFRI, of course, funding cancer research that from the money that funneled down from people like Gwen, who did the Terry Fox run. And why a Northern biobank just in general was equity and access to the opportunity to be part of a biobank, and subsequently the biobank being a research infrastructure, the research that would come out of it, and then because the research is so important, the impact that the research will have. Essentially, basically, the more involved you are in the research, the more likely you are to benefit from it, the more excluded you are, the less access you have to it, the less you participate in it, the less that those results will be applicable to you. And that's what Gwen was referring to when she said what I felt like as a surgeon in Northern British Columbia, as with 95%, pretty much almost 100% of my clinical care now being either cancer screening, like in the Scope Clinic yesterday, doing colonoscopies, to cancer care. There's not a single prescription I've ever written for a First Nations or Métis patient. There's not a lot of Inuit in British Columbia, but there's not a single prescription I've ever written that was based on research that included First Nations as a specific target cohort. There's not a single surgery that I've ever recommended based on a First Nations study that was relevant to First Nations. There's not a single screening guideline that I've given out to say, hey, you're due for a screening colonoscopy based on guidelines and programs that included Indigenous specific data. And that's an issue. There's the biobank in the north, increasing the research capacity to be part of it. And I think what's really important is it's not just to be part as a participant, but creating this infrastructure in the north, it can create to be part of it as a researcher, to be part of the biobank, to be part of that infrastructure. It gives that opportunity. It's to be part of not only the answers by participating in the research or being a researcher, but also the ability to ask questions so that we can partner and collaborate and be part of the bigger infrastructure, which is referred to as the Marathon of Hope, or individual nodes that are doing amazing work. Improve participation, access, and capacity to precision oncology and the associated health outcomes. Because in the end, being part of research is fundamentally so that either as someone like in POG or the precision, like that precision oncology program, or future, the knowledge that can help future people that are in your scenario. It's such an empowering ability to be able to do that. It's not so much being in a biobank. I don't think many people would take joy out of being in a biobank, but I think they would take pride and be empowered and feel like something good was coming out of the situation they were in if they were going to be part of the solutions. And that's what I've heard from community members. It's the opportunity to have a choice, where people in the north with no previous biobank, with First Nations people with no previous studies in oncogenomics, to have the choice is so key. And I want to point out that basically this picture, this inaugural research day, and this keynote address, which I thought Marco Mara was crazy to ask me to do because I'm not a genomic scientist. I am not a medical oncologist that uses that in the day-to-day work in terms of the amendment of treatment and understanding. I asked the question, but on this day, I asked a specific question on December 1st, 2011. So the question that really planted the seed for the Northern Biobank, because when I was doing this keynote address in front of a whole bunch of researchers that were way smarter than me, I could understand the value of that translational research that they were doing and that they were sharing on the posters or in the presentations. The role of bench to bedside research was critical, and nobody in that room on that day, nor previously or afterwards, has ever criticized that bench to bedside phenomenon where you can actually improve the care and the outcomes of cancer patients based on what you're doing in a lab and what you're doing at the bench, so to speak. But there was a question that was not being addressed at that time 15 years ago, and it was, what bedsides are getting to the bench? Bench to bedside? No one questioned. but no one asked what bedsides are getting to the bench. So when you looked at what research was being done, it was either being done from tissue, from data that was based on patients who were being seen in metropolitan academic centers that had genome sequencing capacity, or it was from data and or tissue that was being imported from another country. And again, that was 15 years ago almost. So what we started is shortly thereafter, guess what happened? I asked that question at that keynote. I asked what bedsides are getting to the bench, and I actually did not anticipate the massive response from the people in the audience saying, how do we get those populations involved? And it's one of the lessons that I have learned is if you have a question, be careful because you may be called on to answer that. And so I'm not going to spend too much time in explaining this, but for the most part, it started right, a few months afterwards in terms of 2012, discussions, consultations with researchers, biobankers, First Nation partners, community leaders, Northern Health, BC Cancer, funders, research funders about biobanking. So, I was just talking to Peter Watson before this all started when we were in the background, just saying, Peter, I remember one of the first things we did was when we had this idea was reach out to Peter Watson, find out what training we could get from him, find out about what course. The first course that was available was in Winnipeg. So off we went to Winnipeg and we asked Peter for advice, and he was on speed dial for a number of years as we developed the background for the biobank. We then eventually got funding and we went into formal consultations. And this is some of the data to sort of show the distribution of this. We went across the North, 55 First Nations, but we also included the general public. We included students and trainees. We included funding agencies, research institutions and partners, and national and international partners that were doing similar things around the world. And since then, the community has been part of this every step of the way. To give you a timeline, there's where it started. This is basically the progress of it. We did a DNA on Loan workshop that was international based on Indigenous data and Indigenous biobanking. In the spring, we finally developed the advisory for the First Nations consultations, and ultimately the consultations were completed in 2019 because the COVID pandemic cut them short. Ultimately, when we look at that and we kind of go back, the First Nations Biobank governance was approved. Peter Watson said, you need a governance. You need a governance in order to move forward. This is exceptionally important when it comes specifically to First Nations Biobank data and biospecimens. And that governance was approved with a chief in one of those 55 First Nations presenting a motion at where there's a gathering of the regional caucus where the chiefs were there. It was voted on. But how it happened was interesting. I was intensely nervous because, as you can see, this was November 2023. This was, about almost 12 years after I started this. And here it was. Was the governance going to be approved? If it wasn't, we couldn't go forward. And so as we did the presentation, the motion was put forward. The motion was seconded by another chief, and they were about to vote. And essentially, the person that was running that regional caucus said, are there any opposed? And it was silent. Are there any abstentions? And it was silent. And I breathed a sigh of relief, like 12, 13, 14 years of work, and the voices from the communities and the leaders and the health directors and the chiefs and elders and the knowledge keepers. I was like, whoo! And then all of a sudden, one of the chiefs stood up and as the person said, there it is, it's passed. And a chief stood up and she said, no, don't. And my heart sank and I thought, what's going to happen? And she said, I have been asked to come forward and vote. I want the ability to vote on this. And she held up her voting paddle is to say that she voted yes for the Northern BC First Nations Biobank. And then slowly the other chiefs stood up and held up their paddle. They wanted, not only did they vote for this, but they wanted the ability to vote for something they had never been given the opportunity to vote for before. Now, if that's not passion and support, I don't know how else you can capture it. But if anyone can figure it out, let me know. There's 3 facets of the biobank. One of them is what we were just talking about, the Northern BC First Nations Biobank, which requires additional governance. One is the retrospective Northern BC Breast Cancer Biobank, which we developed historically, retrospectively, to ensure that we could have the capacity to do this. And Peter Watson was a big part of that. And we're planning on launching the prospective biobank, which is similar to other biobank processes. The retrospective biobank, you can find all of this. It's about 1,000 cases, and it's pretty standard. Thanks out to Dr. Mungle and Dr. Jones at the Michael Smith Genome Sciences Center for doing the confirmation that what we have there in FFPE is our good tissue blocks for biomedical research, and to Dr. Huntsman, who's doing a tissue array micro project on the biobank as well. The prospective biobank is going to be focused first on breast cancer, colon cancer, and GI cancers, thyroid and melanoma, with an estimated of about 300 to 400 cases in Prince George alone per year. And then what we're aiming to do really is to create a scientific oversight committee, which is one of the next steps. Remembering that this is a biobank, but this is a biobank enabling genomic research in a community hospital. The First Nations Biobank is something that is going to be require that additional governance, not just the scientific oversight committee of the Northern Biobank, but an additional governance structure. It is aiming to increase research capacity, equity and access, but improved health outcomes for all Canadians. We are Indigenous peoples in Canada, and understanding of cancer for one group can help understanding of cancer for all. The Indigenous data governance is important because when you're talking about that data governance, that importance, there also has to be the concept of Indigenous data sovereignty that's embedded within that. We have the governance table. This was approved by the chiefs, as I stated, and we're planning on having our first meeting in June to get things moving with respect to the development of the Northern BC First Nations Biobank in terms of operationalizing it. So what's next? The Northern BC Biobank, we have the RB approval. It's been renewed. There's an operational approval form that Northern Health needs. We're waiting for feedback on that. The privacy impact assessment, we're waiting for feedback on that. And we've just found out there's a legal founding agreement that needs to be processed. And thanks to people like Jessica Nelson and Holly Longstaff for helping us in that area. The retrospective biobank, we're pretty much ready to go in the same way with respect to REB approval. We're waiting for that operational approval, and the privacy impact assessment has to be redone because now we're utilizing it. And again, the same thing, we just found out about the legal funding agreement requirement. What's next? We need to remember those lessons we've learned over the past 15 years. The documentation is completed and improved. We need to do another community launch. This is the launch of phase 2 with our previous MLA, Shirley Bond, but we need to do another community launch to bring everyone on board. The SOC, or the Scientific Oversight Committee, needs to be established and operating. The governance circle, as I described. Our first utilization that is planned when we launch that prospective Northern BC First Nations Biobank and the Northern Biobank overall is going to be with the Marathon of Hope, and we're looking forward to being an active member in keeping the north part of the DNA. First Nations people need to have a choice, and we need to make sure that we move forward in a good way, and we need to all move closer to realizing Terry's dream to finish it. Thank you, Miigwech.
Thank you so much, Nadine, for that phenomenal presentation. And thank you, Gwen, for joining us and for sharing your thoughts as well. Yeah, we're very, very thankful to you both. Thank you. Jenny, I think you had a question.
Do we have time? I mean, Gwen, thank you for such a powerful message And what I liked about what you said is that you chose to walk with Nadine. And I think we can all make choices on what we can do to support what all Canadians need. And so I guess a question, you know, if we have time for answers or not, I would like everyone to think, like, how can Canadians walk with you, all the researchers doing this incredible work in the background and a long time commitment to this? How can we help support biobanking and research for all Canadians? How do patients get involved? What do we say to our clinicians? This is a presentation from the background work to where the rubber hits the road in clinic bedside, right? So I'm just curious if you have any tips for patients and Canadians.
Well, Jenny, I'll just say there are lots of ways that we could improve the way biobanking works, because one of the stumbling blocks is getting the question to a patient or a potential participant and actually asking the question, do you want to be involved? Are you willing to provide specimens and data? And this is what's involved. This is why we're asking. And it's actually getting that question in front of people, particularly for patients who are facing challenges when you become a patient. And so it's a delicate balance. So I think I won't go on into ideas for solutions right now, because I think we're short on time, but I think the more we could get working with patient partners, the more efficient we'll be and the faster research will travel. But also the other thing I'll say is getting involved in governance of biobanking is another very strong way to do it. And I think Nadine's described a really powerful way to improve research by engaging participants in this key first step. So I'll stop there.
Thank you.
Thanks, Jenny. It's a great question, and I agree as usual with Peter. So many times over the past, particularly the last couple of years, as COVID has come to an end and we're looking to launch this biobank, and then there's another kind of process or another form that needs to be filled out, or another like process that needs to be undertaken that we weren't aware of. I feel like we're almost on the cusp of getting there. And I could tell you that one thing that actually I think is incredibly powerful is when I can share stories. I'm a big believer, despite the fact that I'm creating like databases and biobanks. I'm a big believer in the patient stories and community stories. And so when I can say at a meeting with the Northern Health Board or with a research funder that I get phone calls from people who, their father was just diagnosed with stage 4 colon cancer. And I think they're calling me because, well, maybe I did, their colonoscopy and they're asking me for clinical advice, but they're not. They want to know, when is the biobank starting, because they want their father in the biobank. And that is so incredible that they are going through that, or they are personally diagnosed, and they want to know, can they be part of the biobank? Or they hear about the biobank and they're like, I had breast cancer, I had surgery 6 years ago. Is there a way that I can get into the biobank even though it was 6 years ago? These kind of stories are what fuel an engine when there's any kind of resistance to why. Because we're really trying to do this to serve the people of Canada. And I think the people of Canada are either cancer survivors personally, or a loved one, or we're afraid of getting cancer.
Yeah.
There's no one that is not touched by cancer. And I think this is why the Marathon of Hope is such a powerful, powerful engine to get these things done. Thank you.
Thank you. Wonderful. Veronique.
Thank you, André.
Hello, hi Nadine, that was
André.
great. Thank you, Gwen, as well. Fantastic, congratulations. I have a question, Nadine. So when you were mentioning patients or family members contact us and they say, can I be part of the biobank? So what are the criteria for being admitted in the Northern Biobank? Is it First Nations, Métis, Inuit only, or because there are other people presumably who live there, right?
Yeah, great question. So with respect to the retrospective biobank, it was anyone who was diagnosed with breast cancer between those years retrospectively. And it didn't matter where in Northern Health Authority geographic region they were diagnosed. It didn't matter anything else, male, female, it didn't matter First Nations or not, or other, it didn't matter age, nothing. When it comes to the Northern Biobank, that is a biobank that is intended to address the inequity in access to research and the subsequent impact on the precision medicine and oncogenomic care for anyone within the Northern Health. So we're starting off, the communities asked for it to be cancer-based. And we have picked the malignancies that are one common, so breast and colon. We've added thyroid and melanoma. We have to recognize that, for example, lung is not in there because we don't have a thoracic surgeon. You know, there's sarcomas are not in there, which would be amazing, given that this is the Marathon of Hope. All ortho-oncology goes to Vancouver. There's no orthopedic surgeon that does, like, so we've really kind of, it's not that we're including all of them, but we do plan on expanding. So the Northern Biobank is for the North. And it will be ultimately, the only thing it will never include are pediatrics, because all pediatric cancer goes down to the Children's Hospital, and they have a wonderful biobanking program. The Northern BC First Nations Biobank is going to be open to those who identify as First Nations within the Northern Health Authority geography, which is also the northern region of the First Nations Health Authority. But we are being asked, can this expand provincially? And then one of the things we really want to do is working with the Marathon of Hope and working with the First Nations Health Authority and working with other Indigenous institutions and organizations is how can this, what we learned since those first days, how can we share that so that other jurisdictions across the country can use that? And then in addition to that, similar efforts are being made with the Maori in New Zealand, with the Indigenous and Torres Strait Island, Indigenous Australians and Torres Strait Islanders. And so there's lots of ongoing partnerships that are part of this as people kind of watch and see, you know what, not only is the progress of the Northern Biobank and the Northern BC First Nations Biobank there, but I can say that the support that places like the Marathon of Hope have put into this, BC Cancer, the Genome Sciences Center, Genome Canada, CPAC, Northern Health, the fact that we have been supported for a biobank when it's not technically a research project, but research funding agencies are there, and then being taken under the wing of the Marathon of Hope to be part of this initiative is just as exciting to those around the globe working in this field as it is the actual creation of the biobank, because they can say, you know what, in Canada, the Marathon of Hope is happening and they are supporting the Northern Biobank. They don't need to, technically speaking. You guys made the 15,000 plus for the gold cohort. That was done without the Northern Biobank. But you know what? We still feel like we are part of it. We are in that. We are in the trenches. We were welcomed. We were supported. And that's not a price tag. That is what you need to make sure that the community feels like it's taken longer than we thought, but we got the support and we're going to get there.
Very good.
Thank you so much. I know we're past the hour. We do have a couple comments in the Q&A for CTRNet that some people are quite keen to learn more about my bio key and to be, I guess, kept up to date with progress on that. So I guess maybe one question is there a way that people, is there a mailing list or something that people can sign up for, or perhaps we can share updates through the Marathon of Hope mailing list as well?
So anybody who's really interested in the project, they can contact us, because we're also looking for people who are going to be beta testers for some of the work that we're doing, because we do want to be, we want it to be visual and we want it to be intuitive. So if you're a potential end user, just contact me directly and I'll send you on to the team. And yes, in subsequent newsletters maybe, or info letters that you put out, we can, when we get to when we have a minimal viable product as Nicola likes to say, then we can tell you about that.
Fantastic. Great. Well, given that we're over time, I think we're going to have to wrap it up there. But thank you again so much to all of our speakers. Thank you for joining us today and for sharing your work. And thank you for the work that you do, as well as all the network members here. And thank you so much to Jenny for joining me today. And of course, all members of our patient working group. And given that this is about biobanking, thank you to everyone out there who shares their biospecimens and their clinical data and their information and their experience. It really does make research better. And I think Nadine made that showed that very eloquently in your presentation. So thank you, everyone. I am going to drop a link in the chat for our next seminar. It is next week. It's the first of 4 seminars highlighting projects funded through the Patient Voices in Research program. So please join us for that if you're able. And thank you so much for joining us today. I hope you all have a great day.